Good morning, everyone. I'm Dr. Maya Abdelnabi, Assistant Professor of Ophthalmology. Our lecture today is about the ocular motility disorder. The ocular motility disorders include the cranial nerve palsy, the nystagmus, and the myasthenia gravis. First, we are going to start with the ocular cranial nerve palsy. Generally, the causes that can affect the nerve supply of the ocular muscles include: first, intracranial compression like aneurysm, tumors, herniation, microvascular disorders, on top the diabetes and hypertension, trauma, congenital, and this is rare but it does occur, increased intracranial pressure, whether due to tumors, idiopathic intracranial hypertension, in the children, the hydrocephalus, and this particularly affect the sixth nerve. Cavernous sinus lesion, the orbital apex lesions, whatever the causes that cause these lesions, and the inflammation in the vitreous part of the temporal bone that do happen in severe cases of otitis media, and it particularly affect the abducens nerve. ناخد مراجعة سريعة على الانatomical background. We do have 6 muscles in the eye and 3 nerves are responsible for its supply. The fourth cranial nerve, which supply the superior oblique muscle, the sixth cranial nerve, which supply the lateral rectus muscle, and the rest of the extraocular muscles are supplied by the superior and the inferior division of the third nerve, which is called the oculomotor nerve. And this is the summary for the nerve supply and the action of the extraocular muscles. Let's revise quickly the action of the extraocular muscle. The medial rectus, which is supplied by the third cranial nerve, is the main adductor of the eye. The lateral rectus, which is supplied by the sixth cranial nerve, is the main abductor of the eye. The superior rectus muscle, supplied by the superior division of the oculomotor nerve, is responsible mainly at the primary action in the elevation of the globe in the abduction position. A secondary action that it can do is the adduction, and tertiary action is intorsion, which is tilting of the eye inward. The inferior rectus, which is supplied by the inferior division of the oculomotor nerve, its main action is depression in the abducting position. Secondary action is the adduction, and tertiary action is the extorsion. The oblique muscle, the superior oblique, which is supplied by the trochlear nerve or the fourth cranial nerve, its main action is intorsion, to turn in of the globe. And secondary action is depression in adduction, and tertiary action, which is the minimal rule, as an abductor of the eye. The inferior oblique, which is supplied by the inferior division of the oculomotor nerve, its main action is extorsion. Secondary action is elevation in adduction, and its tertiary action is abduction. And in the clinical rounds, we are going to discuss the origin, the insertion, and the actions in detail. What about the ocular motility? We do have 3 types of ocular motility that will be discussed in our clinical rounds, which is the duction, which is the monocular eye movement. Duction means the monocular eye movement, the movement in one eye. Okay? Verging, binocular eye movement, which is the movement of both eyes but in the same direction, and vergence, which is the movement of both eyes in the opposite direction. In every direction and in each type of these extraocular, in each type of this ocular motility, we do have muscles responsible too. For example, if we want to move the eyes to the left, to move the eye to the left, the lateral rectus of the left eye will act together with the medial rectus of the right eye. What is the clinical presentation of the cranial nerve palsy? Any patient having cranial nerve palsy will be represented by the following. Number one, manifest strabismus. Manifest ocular deviation. Limitation of the ocular motility in the direction of the action of the paralyzed muscle, means that the eye cannot do the action of the paralyzed muscle. Variability of the angle of the deviation, means the angle of this deviation will vary according to the direction of the movement of the eye and according to the paralyzed muscle. Binocular diplopia. What's diplopia? Diplopia is seeing double image. Binocular diplopia means a double image is seen when both eyes are open, and this diplopia disappears once any of the both eyes are covered. And this diplopia increase in the field of the action of the affected muscle. Abnormal head posture. What is the aim of assuming an abnormal head posture? The abnormal head posture, the patient do it in order to overcome the binocular diplopia. He tends to change the position of his head, face, and chin to bring it in the position of the paralyzed muscle so that he can overcome his own diplopia. First of all, we are going to talk about the third nerve palsy, or the oculomotor nerve paralysis. As we said before in the lecture, that the oculomotor supply most of the extraocular muscle in addition to the intrinsic muscles of the eye, which is the sphincter pupillae by parasympathetic innervation, and this is responsible for the meiosis, of the pupil, and the ciliary muscle, which is responsible for the accommodation. We have to put in our mind that the cranial nerve, the third cranial nerve palsy may take various forms. It may be a case of total ophthalmoplegia, means that all the extrinsic and the intrinsic muscles are affected. Or it may be partial ophthalmoplegia. Partial means one of the division, whether the superior or the inferior division of the oculomotor nerve is affected, and subsequently the muscles supplied by this division are affected. Or it may be external ophthalmoplegia, only the extrinsic muscle like the lateral rectus, like the levator palpebris superioris, the superior rectus, the medial rectus, the inferior rectus, and the inferior oblique muscles are affected. But the muscles supplied by the parasympathetic innervation are spared. Or it may be only internal ophthalmoplegia, which means that the intrinsic muscles are only affected, the sphincter pupillae and the ciliary muscle, and there is no affections in the other extraocular muscles. So whenever we are facing a patient with oculomotor nerve palsy, we have to know which part is affected in the nerve, or there is a complete total ophthalmoplegia. Our first case, we are going to talk about complete third nerve palsy, means that all the intrinsic and the extrinsic muscles of the globe are affected. And this is called, this is considered a dangerous sign. First, the patient will be represented clinically by ptosis due to the affection of the levator muscle, which is supplied by the superior division of the oculomotor nerve. Limited ocular motility in all directions except for the abduction, which is done by the lateral rectus, and this is nerve supply in the sixth nerve, and slight depression, which is done by the superior oblique, that is supplied by the trochlear nerve. And as considered that as the parasympathetic portion of the nerve is affected, the pupil will be dilated, non-reactive, and the patient will lose his accommodation. Does this patient is going to complain from diplopia? No, because of the ptosis. The ptosis cover the affected eye, so the patient doesn't have diplopia, doesn't need to assume any head posture. Okay? What are the causes of the complete third nerve palsy? it is the same causes of the cranial nerve palsy, but we have to put in our mind first the dangerous causes, like a compressing aneurysm, and the most common aneurysm is the aneurysm between the posterior communicating and the internal carotid artery, okay, or brain tumors, brain herniation. These are all the causes responsible for the total affection. But this does not mean that it may be a benign causes. No, it may be benign, but we have to put in our mind first the dangerous causes. The second type is the pupil-sparing third nerve palsy, which means that there is only affection of the extraocular muscle, not the muscle supplied by the parasympathetic innervation. The patient will have ptosis, which will mask his diplopia, as mentioned before, limited ocular motility except for abduction and slight depression, and the pupil will be normally reacting. This type of pupil-sparing third nerve palsy it may hide underneath a dangerous causes, but most of the time it will be benign. Mostly it is due to microvascular disorder, the diabetes and hypertension on top, which causes ischemia of the cranial nerves. Now let's move to the fourth nerve or the trochlear nerve, which is responsible for supplying the superior oblique muscle. As mentioned, the superior oblique muscle is responsible for depression of the eye in abduction and in torsion. So when this muscle is paralyzed, the opposite will happen. Now, the patient will be having diplopia, but vertical diplopia. He will see the image above each other because the defect is in elevation and depression, not in adduction and abduction. So this is called the vertical diplopia. And in the primary position, while the patient is facing you, he will have hypertropia or elevation of the globe in the affected eye, because one of the depressors of the eye, which is the superior oblique, is affected. And as long as the superior oblique is affected, its antagonist, which is the inferior oblique muscle, start to act more. So there will be excessive elevation in adduction due to the inferior oblique muscle overaction. So if we revise this picture, you will see that the patient is having limited depression in adduction. He has normal abduction and adduction because this is managed by the medial rectus and lateral rectus. He has excessive elevation of the affected eye due to the overaction of the inferior oblique, which is not antagonized by the superior oblique muscle. This patient is having a very annoying vertical diplopia, and so he tends to assume an abnormal head posture. How did he do this head posture? He started to move his head and face in the direction of the action of the paralyzed muscle. For example, if we are having left superior oblique palsy, the patient is unable to bring his eye down in the adducting position. So he starts by depressing his chin, tilting his head and face to the opposite direction of the paralyzed muscle. He brings his face and head in the direction of the action of the paralyzed muscle to overcome the annoying diplopia. The causes of the fourth nerve palsy, it is the same causes as discussed before. As regards the sixth nerve, which is the abducent nerve, in the primary position, the patient is having annoying esotropia. Why? Because the abducent is responsible for supplying the lateral rectus, which is the main abductor of the eye. So when the abduction is lost, the medial rectus takes the upper hand and the eye will be in adducting position, which causes esotropia. There will be, as seen here, defective abduction. Look, by asking the patient, the affection is here in the left eye. We ask the patient to move his eyes to the left. He cannot abduct this eye, but there is normal adduction. This patient will have an annoying horizontal diplopia. He means that he will see the double image beside each other because the lateral rectus is responsible for abduction. And definitely he started to assume a head position to overcome his diplopia. How? He now cannot move this eye in the abduction, right? So he started to turn his face in order to overcome the diplopia. So the patient assumed an abnormal head position in form of face turn to the same side of the lesion to minimize the diplopia. How to manage the cranial nerve palsy? This is considered one of the ocular emergencies. We have to refer to the ophthalmologist to confirm the diagnosis, and we have to ask for urgent investigation in form of neuroimaging. MRI brain is ordered together with imaging of the vessels of the brain like MRV and MRA, which is the magnetic resonance angiography, to view the arteries, and the magnetic resonance venography to view the veins in the brain. These are urgent to be done, MRI, MRV, and MRA, to make sure that there is no dangerous sign, aneurysm, tumors, herniation. And if the patient is giving us a history of diabetes, hypertension, atherosclerotic disorder, we have to check for the blood glucose level, the lipid profile, check blood pressure. Okay, the first of all, we have to exclude serious causes. And if inferior causes is discovered, we have to refer it to its subspecialty, mostly neurosurgery. If there is no serious cause is discovered and the patient is just diabetic, hypertensive, or atherosclerotic, we have to done for him the general blood examination, the general blood investigation, together with the cardiac evaluation, and refer him to an internal medicine specialist. But what about his eye? What are we going to do? First of all, we have to treat the cause of the nerve palsy. And then we will do temporary measures till a period of 6 to 9 months pass. We give the nerve a period of 6 to 9 months to allow for the regeneration. During this period, all what we are worried about is the annoying diplopia of the patient. So we can use temporary measures like monocular occlusion or the prism, which is prescribed in glasses. After 9 months, if the nerve regeneration doesn't do what it has to do, we can proceed to surgery to return the globe back to its aligned position. This is in short the ocular motor nerve palsy, and we are going to discuss the details of the ocular muscle assessment and how to measure the deviation and how to deal with in the clinical rounds. The second disorder is the myasthenia gravis, and I guess that you do have a background about the myasthenia gravis. First of all, it is an autoimmune disease that affects the skeletal muscle, but it does not affect the cardiac muscle or the involuntary muscles of the body, and this is due to autoimmune process as mentioned, and it tends to affect people at any age, but most commonly the females less than 40 and the males older than 60. What is the main features of the myasthenia gravis? The main feature is the fatigability. The muscles cannot maintain its action. It tends to get tired and it loses its action due to a defect in the acetylcholine receptors in the muscles. There is antibodies against the acetylcholine receptors that are present in the muscle. So the main feature is the fatigability. Whenever you see this patient, they are unable to open their eyes for a long time, unable to move for a long time, unable to carry the stuff that are used to carry, unable to do the usual daily work that he used to do it. Okay, so the main feature is the fatigability, and this fatigability improves by rest. Moreover, it is variable, means that we have good times and bad times. Sometimes you see this patient as a normal patient, especially in the morning or especially after he had a period of rest, and then you may see him affected particularly by the end of the day or if he done a lot of work for a long time. In more than half of the people who develop myasthenia gravis, their first presentation is ocular symptoms. This patient may have ptosis, diplopia due to affection of the ocular cranial nerve, but on examining this patient on different settings, the presentation will be variable. The degree of ptosis will be variable. The angle of deviation will be subject to variability. The ptosis, it may be it's an insidious onset, bilateral, frequently asymmetrical. As mentioned, it's worse at the end of the day and least on the morning, worse on prolonged up gaze due to fatigue. If you want to ensure that the patient ptosis is due to myasthenia gravis, we do a simple test in our clinic, which is the ice pack test. When the patient is having ptosis, we bring an ice pack, put it in the eye for 2 to 3 minutes, and then start to examine. You will find that will be improvement in the ptosis. If the test is positive, this means that this is a myasthenic patient, and this is due to the fatigability of the levator muscle. If the patient does not improve, then we will search for the other causes of ptosis. Again, the extraocular examination may mimic any pupil-sparing ocular motility because the myasthenia gravis does not affect the involuntary muscles. But there will be a bizarre defects زي ما قلنا، يعني بمعنى bizarre defects you will have a variable presentation during the same setting of examination and along different examination setting. There may be also lack of facial expression, which is called the mouse face, dysphagia, dysarthria, difficulty with breathing, and this is a serious condition. Whenever you discover a myasthenic patient, you are afraid of the respiratory failure. Weakness, particularly of the arms and the proximal muscles of the leg. How to manage the myasthenia gravis? Refer to ophthalmologist and neurologist to confirm the diagnosis. The tests done are the hydrophonium test, which is to inject the cholinesterase inhibitor to give more time for the acetylcholine to act at its site. Acetylcholine receptor antibody level. Electromyography, which measure the strength of the muscle. There is no cure for the myasthenia gravis because it is an autoimmune disease. It's a lifelong treatment. We give the patient anticholinesterase drugs, steroids, and in severe cases we may give immune suppressive drugs. The last aspect in our lecture is the nystagmus. You don't need to know a lot about the nystagmus, except that this is involuntary, rhythmic, to and fro oscillation of the muscles of the eye. It may be vertical, horizontal, rotatory, or a combination. This nystagmus may be physiological at the end gaze nystagmus when we look in the severe gaze, or it may be drug-induced, may be congenital. Only the acquired form of the nystagmus, which require full neurological evaluation and MRI, and usually the patient can complaining of oscillopsia and vertigo. This may be caused by trauma, MS, brain tumors, degeneration of the CNS, and vestibular disease. You don't need to know any more in the nystagmus, and the details will be discussed in the clinical round. Thank you.